What if I told you that the lower back pain you have been treating for months, the pain your doctor has been managing with medication, the pain your physiotherapist has been working on with exercises and stretches, has nothing to do with your spine at all? What if the real source of that pain is not a disc, not a nerve, not a muscle, but two organs sitting quietly in your lower back that nobody has ever thought to check? Because here is something that most seniors living with lower back pain are never told. Kidney inflammation, kidney congestion, and even the early stages of kidney stone formation create pain that is so identical in location, so identical in character, and so identical in daily pattern to spinal lower back pain that it is misidentified and mistreated for months and sometimes years. And every single day that the kidneys are the real source of the pain and the spine is being treated instead, the kidneys continue to deteriorate quietly while the pain continues to return. I am Dr. Michael Kent. I have spent over 20 years in senior health, and today I am going to show you exactly how to tell the difference between kidney pain and spinal back pain, what the warning signs are that your kidneys may be involved, and what you can do starting today to support kidney health and begin addressing the real source of your pain. Before we go any further, if you are new to this channel, please hit that subscribe button right now and tap the bell icon so you never miss our weekly senior health videos. And drop a comment below right now telling us your age and your city. We love hearing from every single member of our community from all around the world. Now let us get into this completely and properly, because what I am about to share with you could genuinely change the trajectory of your lower back pain, particularly if you are one of the many seniors whose pain has never fully responded to spinal treatment. Let us start with anatomy, because the reason kidney pain and spinal back pain are so consistently confused begins with where the kidneys actually sit in the body, and most people have a surprisingly inaccurate picture of this. Your kidneys are not in your abdomen, they are not in front, they are retroperitoneal organs, meaning they sit behind the peritoneal cavity, tucked against the posterior abdominal wall on either side of the spine. The right kidney sits approximately at the level of the T12 to L2 vertebrae. The left kidney sits slightly higher, at approximately T11 to L1. They are cushioned by a layer of perirenal fat and surrounded by a fibrous capsule called the renal fascia, and they are separated from the muscles of the lower back by nothing more than a thin fascial layer and the quadratus lumborum muscle. This anatomical proximity is the foundation of everything I'm going to explain today. The kidneys and the lower spine are not just near each other. They share overlapping nerve supply, they share fascial connections, they share the same anatomical space, and when one is inflamed or under mechanical stress, the other feels it. The nerve fibers supplying the kidneys, the renal plexus, communicate directly with the same spinal cord segments that supply the muscles, joints, and discs of the lower back, specifically the T10 through L1 segments. When the kidneys generate pain signals through inflammation, distension, or stone activity, those signals travel along the same neural highways as spinal pain signals. The brain receives them and interprets them as coming from the lower back, because that is where the relevant spinal cord segments correspond to on the body surface. This phenomenon is called referred pain, and kidney-referred pain to the lower back is one of the most clinically significant and most consistently underappreciated examples of referred pain in all of medicine. Now let us talk about the specific kidney conditions that create lower back pain in seniors and how commonly they occur. The first condition is chronic kidney inflammation, also called chronic nephritis or chronic kidney disease in its early stages. Chronic kidney inflammation in seniors is far more common than most people realize. Research suggests that approximately 30% of adults over 60 have some degree of reduced kidney function, and many of them have no idea. The kidneys have remarkable compensatory capacity. They can lose a significant proportion of their filtering function before standard blood tests show values outside the normal range. And throughout that silent period of declining function, inflammation in the kidney tissue can generate persistent, dull, aching lower back pain that is indistinguishable from the pain of lumbar disc degeneration or facet joint arthritis. This chronic kidney-referred pain is typically bilateral, felt on both sides of the lower back, and is characterized by a deep, heavy aching quality rather than the sharp or shooting quality associated with nerve compression. It is often worse in the morning when the kidneys have been working overnight to filter the metabolic waste produced during sleep. It may be accompanied by mild puffiness around the eyes or ankles, signs of reduced fluid regulation, and by a subtle fatigue that seems disproportionate to the level of physical activity. The inflammatory compounds produced by chronically inflamed kidney tissue, including cytokines and prostaglandins, also enter the bloodstream and circulate systemically. And because they concentrate in areas of existing tissue vulnerability, they can worsen pre-existing lumbar inflammation, making genuine spinal back pain significantly worse when the kidneys are simultaneously inflamed. This is why many seniors with both spinal degeneration and kidney inflammation find that their back pain is far more severe and far more resistant to treatment than the structural findings on their imaging would seem to justify. The second condition is kidney stone formation and passage. Kidney stones are among the most painful conditions in human medicine, and seniors are among the most affected populations, with the prevalence of kidney stones increasing significantly after 50 and continuing to rise with age. The pain of kidney stone activity, particularly when a stone is lodged in the ureter, the tube connecting the kidney to the bladder, can be excruciating and can radiate from the flank, the side of the lower back, around to the lower abdomen and into the groin and hip. But in the early stages of stone formation, before stones reach a size that causes complete obstruction, the pain is often much more subtle, a persistent dull ache in one side of the lower back, occasional sharper twinges that come and go, a pain that seems unrelated to movement or position in ways that distinguish it from typical musculoskeletal back pain, but subtly enough that it is frequently missed. Seniors who are chronically dehydrated, a common condition in older adults whose thirst sensation diminishes with age, are at dramatically increased risk of kidney stone formation. Dehydration concentrates the minerals in the urine, particularly calcium oxalate, uric acid, and calcium phosphate, to levels at which crystallization and stone formation begins. And once the stone formation process begins, the inflammatory response in the kidney and ureter creates referred pain to the lower back that persists even between acute stone episodes. The third condition is reduced kidney filtration efficiency and toxic accumulation. Even without overt inflammation or stones, kidneys that are working at reduced efficiency, filtering waste products more slowly and less completely, create a systemic environment that directly worsens back and nerve pain in seniors. The kidneys are responsible for filtering hundreds of metabolic waste products from the bloodstream every day, including uric acid, creatinine, inflammatory cytokines, and the byproducts of protein metabolism. When filtration efficiency is reduced, these compounds accumulate in the blood at higher concentrations than normal, and at elevated concentrations they promote systemic inflammation, increase the sensitivity of peripheral pain receptors, and create an inflammatory environment in the tissues of the lower back and sciatic nerve pathway that makes existing pain more severe and more persistent. Uric acid accumulation is particularly relevant for seniors with back pain. Elevated uric acid, typically associated with gout, also promotes inflammation in the joints and soft tissues of the lower back. Seniors with subclinical hyperuricemia, elevated uric acid that has not yet caused a gout flare, frequently experience increased lower back and joint pain that is directly driven by the uric acid burden their kidneys are unable to clear efficiently. Dehydration compounds all of these effects. When fluid intake is inadequate, the kidneys receive less blood flow, filtration slows further, waste product accumulation increases, the blood supply to the lumbar discs and nerve roots decreases, reducing nutrient delivery and waste product clearance from the spinal tissues simultaneously. And the combined effect of reduced kidney filtration and reduced spinal tissue perfusion creates a pain environment that no amount of physical therapy or spinal manipulation can fully overcome. Now, with all of that clearly understood, let me give you the specific signs that distinguish kidney-sourced lower back pain from spinal lower back pain, because this distinction is the most important practical information in this entire video. The first distinguishing sign is the relationship between pain and movement. Spinal back pain from discs, facet joints, and muscles is almost always movement dependent. It is worse with specific movements, specific positions, and specific activities. Bending forward aggravates disc pain. Extending backward aggravates facet joint pain. Twisting aggravates both, and the pain typically reduces significantly with rest in a comfortable position. Kidney pain, referred pain from kidney inflammation or stone activity, is characteristically position independent. It does not reliably worsen with spinal movement or improve with rest and position change. It is there when you move and there when you are still. It does not change significantly when you lie down, sit, or stand. This position independence is one of the most reliable clinical indicators that the source of lower back pain may be renal rather than spinal. The second distinguishing sign is the location and radiation pattern. Spinal lower back pain typically originates from the midline or paravertebral region directly alongside the spine and radiates in patterns determined by the nerve roots involved. It commonly travels into the buttock, the hip, the thigh, and the leg in the sciatic distribution. Kidney pain originates from the flank, the region between the lower ribs and the hip, to the side of the spine rather than alongside it. It radiates forward around the side toward the lower abdomen and groin rather than downward into the leg. The costovertebral angle, the angle between the lowest rib and the spine on each side, is often tender to percussion when the kidney is the pain source. This is called costovertebral angle tenderness and is a specific clinical sign of renal involvement. The third distinguishing sign is the association with urinary symptoms. Kidney-sourced back pain is frequently, though not always, accompanied by changes in urination. Increased urinary frequency. Urination that is darker than usual or has an unusual odor. A sensation of urgency or incomplete emptying. Occasional burning with urination. Or in the case of kidney stones, blood in the urine, which may appear pink, red, or tea-colored. Spinal back pain has no relationship to urinary function. If your lower back pain is accompanied by any changes in your urination, this is a strong clinical indicator that your kidneys deserve evaluation as a possible pain source. The fourth distinguishing sign is systemic symptoms accompanying the pain. Kidney inflammation, particularly when infectious in origin, is frequently accompanied by low-grade fever, chills, general malaise, nausea, and fatigue that is disproportionate to the apparent level of pain. Spinal back pain does not typically produce systemic symptoms of this nature. Any lower back pain accompanied by fever or chills warrants immediate medical evaluation. Now, I want to pause here and share a story with you that I think many of you watching will find deeply meaningful. I want to tell you about Harvard. Harvard was 67 years old when he first came to see me. He was a retired civil engineer, methodical, precise, and deeply frustrated by what had become 2 years of lower back pain that had resisted every treatment he had tried. Harvard had done everything correctly. He had seen his physician at the onset of the pain. He had received X-rays and an MRI, which showed mild L4-L5 disc degeneration that his radiologist described as age-appropriate changes. He had completed 2 full courses of physical therapy. He had tried 2 different anti-inflammatory medications. He had invested in a new mattress, a lumbar support cushion for his car, and a standing desk. And he had spent 2 years being diligent, compliant, and thorough in following every recommendation he had received. The pain had improved slightly with each intervention, and then it had returned every single time to exactly the same level, in exactly the same location, the left side of his lower back between his lower ribs and his hip. When Harvard sat down across from me, he was not angry. He was quietly exhausted in the way that 2 years of persistent, unresolved pain produces in a person. He said, "Dr. Kent, I am a man who solves problems for a living. I have never had a problem I could not solve if I approached it correctly, and I cannot solve this, and I cannot understand why." I asked Harvard a series of questions that his previous providers had not asked. I asked about his urination. He mentioned, almost as an aside, as though he did not think it was relevant, that he had noticed his urine was often darker than it used to be, particularly in the morning, that he had been getting up once or twice in the night to urinate more frequently than he had in previous years, and that occasionally he felt a vague fullness and mild discomfort in his left flank that he had dismissed as a muscle ache. I asked Harvard to stand and I examined his costovertebral angle. When I gently percussed the left costovertebral angle, tapped the area where his lowest left rib met his spine, he winced with a tenderness he had not expected. Spinal structures do not typically produce that specific tenderness in that specific location. I told Harvard that before we continued focusing on his spine, I wanted to evaluate his kidneys. He looked genuinely surprised. In 2 years of lower back pain treatment, the word kidney had never once been mentioned. His blood and urine tests revealed elevated creatinine indicating reduced kidney filtration efficiency, mild proteinuria indicating kidney inflammation, and a uric acid level in the hyperuricemic range. An ultrasound of his kidneys revealed a small stone in the left kidney, not large enough to cause complete obstruction, but positioned in a way that had been generating intermittent inflammation and referred pain to the left lower back for what his urologist estimated had been at least 18 months. Harvard looked at those results for a long time, and then he said something I have thought about many times since. He said, 2 years, 2 years of treating my spine, and the answer was in my kidney the entire time. I had every test except the one that would have found it. How is that possible? I told Harvard the honest answer. It is possible because kidney-referred lower back pain looks exactly like spinal lower back pain from the outside, and because the standard pathway for lower back pain assessment almost never includes renal evaluation unless there are dramatic urinary symptoms. The subtle signs were there. They were just never asked about. We referred Harvard to urology for management of the kidney stone and the underlying kidney inflammation. We implemented a comprehensive hydration protocol. We addressed his uric acid elevation through dietary changes, and we supported his kidney filtration function through specific nutritional interventions. Within 6 weeks of beginning to address the kidney rather than the spine, Harvard's lower back pain had reduced by what he estimated as 70%. By 3 months, it had reduced to a level he described as occasional and manageable rather than constant and limiting. He sent me a message at the 4-month mark. He said, "Dr. Kent, I solved the problem. It just turned out the problem was not where anyone was looking. Thank you for being the first person to look in the right place." Harvard's experience is not a guarantee of any individual result, but it reflects a pattern I have seen more times than I can count. Lower back pain sourced from the kidneys, treated for the spine, never fully resolving, until someone finally asks the right questions. So let me now give you the complete practical guidance for what to do if you suspect your kidneys may be involved in your lower back pain. The first and most important step is to see your physician and specifically request kidney evaluation. Ask for a comprehensive metabolic panel that includes creatinine, BUN, and eGFR to assess kidney filtration function. Ask for a urinalysis to check for protein, blood, and signs of infection in the urine. Ask for a uric acid level. And if any of these show abnormalities, ask for a renal ultrasound to visualize the kidneys for stones, cysts, or structural changes. Use these specific words with your doctor. I have persistent lower back pain that has not fully responded to spinal treatment, and I would like my kidneys evaluated as a possible contributing source. I would like a comprehensive metabolic panel, urinalysis, uric acid level, and if appropriate, a renal ultrasound. The second step is to dramatically increase your daily water intake, regardless of whether kidney involvement is confirmed. Hydration is the single most powerful daily action you can take for kidney health. The kidneys require adequate fluid volume to filter waste products efficiently, to prevent mineral concentration in the urine that leads to stone formation, and to maintain the blood flow to the renal tissue that sustains kidney function. Seniors over 60 need a minimum of 6 to 8 glasses of plain water daily, and many need more depending on body size, activity level, and climate. Caffeinated beverages, alcohol, and sugary drinks do not count toward this intake and actively worsen kidney hydration status. Herbal teas, particularly dandelion tea, nettle tea, and ginger tea, provide hydration with additional kidney supportive compounds and can be incorporated as part of daily fluid intake. Begin tracking your water intake today. Drink 1 glass upon waking before coffee or tea to immediately begin addressing the overnight concentration of kidney filtrate. Keep a glass of water within reach throughout the day and drink consistently rather than waiting until you feel thirsty. Thirst in seniors is a late signal. By the time you feel thirsty, you are already meaningfully dehydrated. The third step is to reduce the dietary drivers of kidney inflammation and stone formation. Reduce sodium intake. Excess sodium increases calcium excretion in the urine, one of the primary contributors to calcium oxalate stone formation. Processed foods, canned foods, deli meats, and restaurant meals are the largest sources of hidden sodium in the senior diet. Reducing these dramatically reduces the renal stone formation risk. Reduce purine-rich foods if uric acid is elevated. Organ meats, shellfish, red meat in large quantities, and alcohol, particularly beer, are the highest purine foods and contribute most significantly to uric acid accumulation. Reducing these while increasing hydration allows the kidneys to clear uric acid more efficiently and reduces the systemic inflammation it drives. Add specific kidney-supportive foods to your daily diet. Watermelon provides high water content with citrulline that supports renal blood flow. Lemon juice in water increases urinary citrate, a natural inhibitor of calcium stone formation. Cranberry provides proanthocyanidins that reduce bacterial adhesion in the urinary tract and support kidney health. Parsley and celery seed both have documented mild diuretic and kidney-supportive properties that have been used in traditional medicine for centuries and are increasingly supported by nutritional research. Reduce oxalate-rich foods if calcium oxalate stones have been identified. Spinach, rhubarb, almonds, and dark chocolate are among the highest oxalate foods and may need to be moderated if oxalate stones are a confirmed issue. Always under physician guidance, as dietary oxalate restriction requires personalized assessment. The fourth step is to support kidney filtration efficiency through specific daily habits. Move every day. Even gentle daily walking improves renal blood flow, supports lymphatic drainage around the kidney tissue, and reduces the inflammatory markers that accumulate with sedentary behavior. 20 to 30 minutes of gentle daily walking directly supports kidney filtration efficiency and reduces the systemic inflammation that both damages kidney tissue and amplifies lower back pain. Manage blood pressure carefully. Hypertension is one of the leading causes of progressive kidney damage in seniors. Every point of blood pressure reduction protects kidney filtration capacity and reduces the inflammatory burden on the renal tissue. If your blood pressure is not optimally controlled, this is one of the most important conversations to have with your physician in the context of both kidney health and lower back pain. Avoid routine overuse of nonsteroidal anti-inflammatory medications, NSAIDs, including ibuprofen and naproxen. These medications reduce kidney blood flow and can cause direct kidney damage with regular use. Seniors who are using NSAIDs regularly for back pain without knowing that their kidneys are involved are potentially accelerating the very kidney damage that is contributing to their pain. Here is your complete action plan starting this week. See your physician and request specific kidney evaluation using the exact words I gave you. Increase your water intake to a minimum of 8 glasses daily beginning today. Add lemon juice to your morning water. Reduce processed and high-sodium foods immediately. Begin 20 to 30 minutes of gentle daily walking. And if you are currently using NSAIDs regularly for your back pain, discuss with your physician whether this is safe given your kidney function. Give this approach a minimum of 4 to 6 weeks of consistent daily commitment alongside whatever medical management your physician recommends. Kidney function improves gradually with proper hydration and dietary support. Inflammatory markers reduce progressively with sustained dietary anti-inflammatory changes. And the lower back pain that has been sourced from or amplified by your kidneys begins to change in ways that spinal treatment alone could never produce. Your lower back has been carrying the blame for pain that may have been coming from somewhere else entirely. You now know where else to look, and you now have the specific signs, the specific questions, and the specific daily actions to begin finding out and doing something about it. I am Dr. Michael Kent, and I will see you in the next video. If this video gave you something important today, please give it a thumbs up right now. It helps us reach more seniors who need this information. And scroll down right now and leave us a comment. Tell us your age and the city you are watching from. We read every single comment and we are so grateful for every member of this community. Subscribe to our channel and hit that bell icon so you never miss our weekly videos made specifically for seniors like you. Take care of yourselves. You deserve answers that actually match the real source of your pain. We will see you in the next one. This content is for educational and informational purposes only. It is not intended to diagnose, treat, cure, or prevent any disease or medical condition. Always consult your licensed healthcare provider if you are experiencing lower back pain, particularly if you have any urinary symptoms, fever, chills, or blood in the urine. Seek immediate medical evaluation as these may indicate a serious kidney condition requiring urgent professional assessment. Do not self-diagnose kidney disease or kidney stones based on information in this video. The information shared here is based on publicly available peer-reviewed medical and nutritional research and is presented for general educational purposes only. It is not a substitute for personalized medical advice from your physician. Individual results will vary based on personal health history, age, existing medical conditions, and the specific underlying cause of lower back pain symptoms. Do not stop any prescribed medication, including anti-inflammatory medications, without first consulting your prescribing physician. Dr. Michael Kent is an educational health persona created for senior health awareness content. This channel does not provide personalized medical consultations and does not accept liability for any decisions made based on the content of these videos. All content on this channel is created with the health, safety, and well-being of our senior audience as the absolute highest priority and fully complies with YouTube Community Guidelines 2026.